Hello. Welcome to Nursing Basics Review for Busy Nurses. For this session, we will study how to read a basic ECG strip, like a pro. Let's get started. First, let us have a quick review on our basic anatomy and physiology. A network of specialized muscle cells is found in the heart's walls. These muscle cells send signals to the rest of the heart muscle, causing a contraction. This group of muscle cells is called the cardiac conduction system. The main parts of the system are the SAW node, AV node, bundle of His, bundle branches, right and left, and Purkinje fibers. The flow of electrical impulse will begin at the SAW node, wherein it will cause the atrial muscles to contract. Sometimes it is also called the anatomical pacemaker. Next, the signal travels to the AV node, through the bundle of His, down the bundle branches, and through the Purkinje fibers, causing the ventricles to contract. This signal creates an electrical current that can be seen on a graph called an electrocardiogram, or ECG. Doctors use an ECG to see how well the cardiac conduction system works. Any changes on the EKG can mean serious problems. The pacemaker dictates the rate at which heart cycles, through pumping action. Every cell along the normal conduction system has automatic pacemaking capability, and has the potential to become a pacemaker. If the pacemaker fails, there will be backup, or a safety net, but at slower intrinsic rate than preceding cells. The general rule is, the fastest pacemaker controls heart. In this slide, normal intrinsic rates in adult ranges are shown. The sinoatrial or SAW node is 60 to 100 beats per minute. This is the normal heart rate. Next is atrial cells, which is 55 to 60 beats per minute. Then, AV node, 40 to 60 beats per minute. Followed by His bundle, 40 to 45 beats per minute. And bundle branches, 40 to 45 beats per minute. Lastly, Purkinje cells, 20 to 40 beats per minute. In case of heart blocks, we will have an idea of where the block is located, depending on the heart rate. Electrocardiography, also known as ECG or EKG, is the process of producing an electrocardiogram, a recording of the heart's electrical activity. An ECG is an electrogram of the heart, which is a graph of voltage versus time of the electrical activity of the heart using electrodes placed on the skin. An ECG paper is a grid where time is measured along the horizontal axis. Voltage is measured along the vertical axis. Each small square is 1 millimeter in length and represents 0.04 seconds. Each larger square is 5 millimeters in length and represents 0.2 seconds. Let us now talk about the elements of an ECG and its points of signal. The ECG waveform is divided into P, Q, R, S, T, and U elements. The P wave corresponds to atrial depolarization, that shows contraction of both left and right atria. Normal duration of P wave is between 0.06 to 0.12 seconds. The PR interval is the conduction time required for an electrical impulse to be conducted from the atria to the ventricles. The duration is normally 0.12 to 0.20 seconds and is important to indicate heart block problems. The QRS complex represents depolarization of the ventricles. The duration of the QRS complex shows how long excitation takes to spread through the ventricles and is usually between 0.06 to 0.10 seconds for normal ventricles contraction. The T wave represents ventricles repolarization, which setting up the cardiac muscle for another contraction. Sometimes, it will follow by U wave, that represents the Purkinje fibers repolarization. The QT interval is measured from the beginning of the QRS complex to the end of the T wave. A normal QT interval is about 0.36 to 0.44 seconds. The Saint segment connects the QRS complex and the T wave. It represents the measured time between ventricular depolarization and the beginning of ventricular repolarization, which normally last about 0.08 seconds. We will now study how to interpret an ECG strip. To be able to interpret an ECG, first, you have to identify the rhythm. Is it regular or irregular? Then, identify what is the heart rate. There are a number of ways used on how to be able to estimate the heart rate. We will study 3 techniques which you can easily use. First on the list is the 6-second strip method. The 6-second strip method is applicable for an irregular rhythm. Here, we can see a 6-second strip. We will count the number of Rs, multiplied by 10. There are 9 Rs, so, we will multiply it by 10. The heart rate is equals to 90 beats per minute. Second, the big box method. Big box method is applicable for regular rhythms. Here, we have a constant number of 300. This number is divided by the number of big boxes between the Rs. In the example shown, we can notice that the rhythm is regular and constant. Most of the QRS complex falls between 4 big boxes apart. So from here, we can calculate 300 as our constant number, divided by 4, which is the number of big boxes. The heart rate is equals to 75 beats per minute. And third, the sequence method. In the sequence method, is applicable for regular rhythms. In this method, we will pick the complex that falls on a heavy line, or nearest. Estimate by counting the heavy boxes. 300, 150, 100, 75, 60, 50, 40, 30. In this example, the QRS complex fell in between 60 and 75. The heart rate is about 60-75 beats per minute. As mentioned earlier, P wave represents the right and left atrial depolarization. Normally, it should be present. Upright, rounded. If inverted, it may indicate retrograde or reverse conduction. If absent, it can be a junctional arrhythmia. Next, we have to determine the PR interval. The normal range is 0, 12 to 0.20 seconds. If less than 0.12, it could mean junctional arrhythmia or pre-excitation syndrome. If greater than 0.20, probably a conduction delay in the AV node, heart block. QRS complex. The QRS complex represents the ventricular depolarization. Normally, it is narrow, but it may vary. It measure 0.060.10 secs or 5 to 30 Because a narrow QRS complex can also mean an SVT. If wide, the rhythm is AV tach. Examine the T wave. The T wave represents ventricular repolarization or relaxation. Normally, it measures 0.5 millimeters, rounded, smooth. A depressed T wave may indicate myocardial ischemia or digoxin toxicity. Elevation could mean MI or electrolyte imbalance, hyperkalemia. Lastly, check for ectopic beats and other abnormalities. Just a quick recap. Rhythm strip analysis requires a sequential and systematic approach. You may find a number of ways on how to do it. Generally, you will be able to interpret an ECG strip using the following steps. First, identify the rhythm, if it is regular or irregular. Then, determine the heart rate, if it is normal, brady, or tachy. Third, identify and examine the P waves, if it is present and upright or absent. Fourth, measure the PR interval, which is 0, 12 to 0.20 secs. Is it normal or prolonged? Fifth, measure the QRS complex, which is 0.060.12 secs. Is it normal or wide? Sixth, examine the T waves. Is it depressed or elevated? Seventh, check for any ectopic beats and other abnormalities. Interpreting a rhythm strip is a skill that requires practice. After following these steps, you can interpret an ECG strip easily. Now, let us proceed to the most common ECG rhythms you might encounter. Normal sinus rhythm is the default rhythm of the heart. Pacemaking impulses originate from the SA node and are transmitted to ventricles via AV node and his Purkinje system. Characteristics of a normal sinus rhythm. Regularity. Regular. Rate, 60 to 100 beats per minute in adults, age-dependent in children. P wave is present with constant morphology. QRS ratio is 1:1. PR interval is constant, normal. QRS interval is normal. Sinus bradycardia. Sinus bradycardia is a sinus node dysfunction with a rate that is lower than normal. Characteristics of sinus bradycardia. RR intervals are constant and regular. Thu rate is less than 60 bpm but not usually less than 40 bpm. All waveforms are present, and there is one P wave to each QRS complex. Patients usually asymptomatic and no treatment is required. Often caused by beta blockers, calcium channel blockers. May also be seen in athletes and occur during sleep. Sinus tachycardia. Sinus tachycardia, also colloquially known as sinus tach or sinus tachy, is an elevated sinus rhythm characterized by an increase in the rate of electrical impulses arising from the sinoatrial node. Characteristics of sinus tachycardia. RR intervals constant and regular. Rate is greater than 100 bpm, but not usually greater than 130 bpm at rest. 1 P wave per QRS complex. All waveforms present. This rhythm normally occurs during an exercise or stress. Patient is usually asymptomatic. Other causes may be hypovolemia, underlying medical problems. Sinus arrhythmia is a commonly encountered variation of normal sinus rhythm. Characteristics of a sinus arrhythmia. Rhythm is regularly irregular. Normal sinus P waves with a constant morphology, no evidence of premature atrial contractions. The PP interval gradually lengthens and shortens in a cyclical fashion, usually corresponding to the phases of the respiratory cycle. Variation in the PP interval of more than 120 milliseconds, 3 small boxes. Constant PR interval. Causes can be respiratory, where the PP interval lengthens and shortens with inspiration and expiration. Non-respiratory, where the process occurs seemingly for no reason. Sometimes seen in association with complete heart block. Arrhythmias. Arrhythmias, also known as cardiac arrhythmias, heart arrhythmias, or dysrhythmias, are irregularities in the heartbeat, including when it is too fast or too slow. Arrhythmias are often categorized into 4 groups: extra beats, supraventricular tachycardias, ventricular arrhythmias, and bradyarrhythmias. Extra beats include premature atrial contractions, premature ventricular contractions, and premature junctional contractions. Supraventricular tachycardias include atrial fibrillation, atrial flutter, and paroxysmal supraventricular tachycardia. Ventricular arrhythmias include ventricular fibrillation and ventricular tachycardia. Bradyarrhythmias are due to sinus node dysfunction or atrioventricular conduction disturbances. Let's study each of them, one by one. A premature atrial complex (PAC) is a premature beat arising from ectopic pacemaking tissue within the atria. There is an abnormal P wave, usually followed by a normal QRS complex. aka atrial ectopics, atrial extrasystoles, atrial premature beats, atrial premature depolarizations. Characteristics. It is an irregular rhythm. Rate varies with underlying rhythm. P waves premature and abnormally shaped contractions. PR interval is usually within normal limits, but varies depending on ectopic fundus. QRS complex is normal. A premature ventricular contraction (PVC) is a common event where the heartbeat is initiated by Purkinje fibers in the ventricles rather than by the sinoatrial node. PVCs may cause no symptoms or may be perceived as a skipped beat, or felt as palpitations in the chest. PVCs do not usually pose any danger. Characteristics. Irregular. Rate reflects the underlying rhythm. P wave, none. PR interval, unmeasurable. QRS complex, early. PVC subtype according to site of origin. Unifocal, single site in the ventricles, monomorphic. Multifocal, multiple sites, different sizes and shape, polymorphic. PVC subtype. According to frequency of occurrence. Bigeminy, every second QRS complex or beat. Trigeminy, every third QRS complex or beat. Quadrigeminy, every fourth QRS complex or beat. Premature junctional contractions (PJCs), also called atrioventricular junctional premature complexes or junctional extrasystole, are premature cardiac electrical impulses originating from the atrioventricular node of the heart or junction. This area is not the normal but only a secondary source of cardiac electrical impulse formation. These premature beats can be found occasionally in healthy people and more commonly in some pathologic conditions, typically in the case of drug cardiotoxicity, electrolyte imbalance, mitral valve surgery, and cold water immersion. Characteristics. Rhythm, irregular. Rate, reflects the underlying rhythm. P-wave, inverted, absent or retrograde. PR interval, not measurable. QRS complex, normal. Atrial fibrillation. Atrial fibrillation, AF or a fib, is an abnormal heart rhythm, arrhythmia characterized by rapid and irregular beating of the atrial chambers of the heart. It often begins as short periods of abnormal beating, which become longer or continuous over time. It may also start as other forms of arrhythmia such as atrial flutter that then transform into AF. Characteristics. The rhythm is irregularly irregular. Rate. If atrial greater than 400 bpm, if ventricular it varies. P waves are absent. PR interval is indiscernible. QRS complex, normal. Atrial flutter, AFL, is a common abnormal heart rhythm that starts in the atrial chambers of the heart. Characteristics. Rhythm if atrial regular, ventricular typically irregular. Rate atrial 250 to 400 beats per minute, ventricular 60,100 beats per minute. Ventricular rate depends on degree of atrioventricular block. P-wave classic, saw-toothed, appearance. PR interval, unmeasurable. QRS complex, normal. Paroxysmal supraventricular tachycardia, PSVT, also called reentry tachycardia, is a type of atrial arrhythmia. It happens when there is abnormal electrical activity in the atria. This is caused by an abnormally irritable area in the atria or by a short circuit in your heart causing electrical signals to travel around and around in a circular pattern. Characteristics. Rhythm is regular. Rate, 150,250 beats per minute. Ventricular rate depends on AV conduction rates. P waves are hidden. PR interval is not visible. QRS complex is normal. Ventricular fibrillation, VFib or VF, is an abnormal heart rhythm in which the ventricles of the heart quiver. It is due to disorganized electrical activity. Ventricular fibrillation results in cardiac arrest with loss of consciousness and no pulse. This is followed by death in the absence of treatment. Ventricular fibrillation is initially found in about 10% of people with cardiac arrest. Characteristics. Rhythm is chaotic. Rate, can't be determined. P wave is absent. PR interval is unmeasurable. QRS complex, indiscernible. Ventricular tachycardia, VTach or VT, is a fast heart rate arising from the lower chambers of the heart. Although a few seconds may not result in problems, longer periods are dangerous, and multiple episodes over a short period of time is referred to as an electrical storm. Ventricular tachycardia can occur due to coronary heart disease, aortic stenosis, cardiomyopathy, electrolyte problems, or a heart attack. Characteristics. Rhythm is regular. Rate, 100,250 beats per minute. P wave, absent. PR interval, unmeasurable. QRS complex, wide. There are two subtypes of VTach. Here, you can see is a monomorphic VTach. There is one wave pattern, wide QRS complex. This rhythm is usually with a pulse. The other type is a polymorphic VTach. Torsades de points, torsade de points or torsades des points, TDP, TSD 2 French. SA DPW, translated as twisting of peaks, is a specific type of abnormal heart rhythm that can lead to sudden cardiac death. It is a polymorphic ventricular tachycardia that exhibits distinct characteristics on the electrocardiogram, ECG. Characteristics. Rhythm. Irregular. Rate. 200-250 BPM. P-wave. Absent. PR interval. Unmeasurable. QRS complex. Wide, bizarre. First-degree atrioventricular block, AV block, is a disease of the electrical conduction system of the heart in which electrical impulses conduct from the cardiac atria to the ventricles through the atrioventricular node, AV node, more slowly than normal. First-degree AV block does not generally cause any symptoms, but may progress to more severe forms of heart block such as secondary third-degree atrioventricular block. Characteristics. Rhythm. Regular. Rate. Normal. P waves. Normal. PR interval. 0.20 seconds but constant. QRS complex. Normal. Second-degree atrioventricular block. Mobitz type 1. Second-degree atrioventricular block, AV block, also known as type 1 second-degree AV block, or Mobitz-Irr-Wenckebach periodicity, is a disease of the electrical conduction system of the heart. It is a conduction block between the atria and ventricles. The presence of second-degree AV block is diagnosed when one or more, but not all, of the atrial impulses fail to conduct to the ventricles due to impaired conduction. Type 1 second-degree AV block is almost always a disease of the AV node. Characteristics. Rhythm. Regular or irregular. Rate. Normal. P-wave. Normal. PR interval. Prolonged. QRS complex. Normal. Type 2 second-degree AV block, also known as Mobitz 2, is almost always a disease of the distal conduction system, his Purkinje system. Characteristics. Rhythm can be regular or irregular. Rate. Normal. P-wave. Normal. PR interval. Normal. QRS complex is normal, then suddenly followed by a dropped beat. Complete heart block. Complete heart block or third-degree atrioventricular block, AV block, is a medical condition in which the nerve impulse generated in the sinoatrial node, SA node, in the atrium of the heart cannot propagate to the ventricles. Because the impulse is blocked, an accessory pacemaker in the lower chambers will typically activate the ventricles. This is known as an escape rhythm. Since this accessory pacemaker also activates independently of the impulse generated at the SA node, two independent rhythms can be noted on the electrocardiogram, ECG. Characteristics. Rhythm. Regular. Rate. Atria 60,100 beats per minute. Ventricular 40 to 60 beats per minute. P-wave. Normal. PR interval. Varied, not measurable. QRS complex. Normal, then with a dropped beat. Junctional rhythm describes an abnormal heart rhythm resulting from impulses coming from a locus of tissue in the area of the atrioventricular node, the junction, between atria and ventricles. Characteristics. Rhythm is regular. Rate is 40-60 beats per minute. P-wave can be inverted, absent or retrograde. PR interval. Not measurable. QRS complex. Normal. Pulseless electrical activity. Pulseless electrical activity, P, refers to cardiac arrest in which the electrocardiogram shows a heart rhythm that should produce a pulse, but does not. Pulseless electrical activity is found initially in about 55% of people in cardiac arrest. Characteristics. Any rhythm, with no pulse, rate. Any rate or no rate. P-wave. Possible P-wave or none detectable. Possible PR wave or none detectable. Possible QRS complex or none detectable. Asystole, New Latin, from Greek privativa, not, without, plus systole, contraction, is the absence of ventricular contractions in the context of a lethal heart arrhythmia, in contrast to an induced asystole on a cooled patient on a heart-lung machine and general anesthesia during surgery necessitating stopping the heart. Asystole is the most serious form of cardiac arrest and is usually irreversible. Also referred to as cardiac flatline, asystole is the state of total cessation of electrical activity from the heart, which means no tissue contraction from the heart muscle and therefore no blood flow to the rest of the body. Characteristics. No rhythm. Rate. None. P waves. Absent PR interval. Absent QRS complex. Absent it looks like a flatline. If you like this video, please don't forget to like and share. Follow us on YouTube, Nursing Basics 22, and on Facebook, Nursing Basics, Review for Busy Nurses. Hit the notification button to subscribe to our channel for our latest updates. Thank you. See you next time. Goodbye.